Hey everyone, this is Fareed Riaz. Welcome to our webinar series. This is, as you all probably got from the email, we hold these these webinars every 2 weeks or so. So I just wanted to welcome everyone. Thank you for showing up. Hopefully this will be a good series for you all. So Dave is going to be introducing our speaker, Dr. Resnick.
Hello. All righty. Thanks, Fareed. Thanks for everybody joining tonight. I'm very excited to have Dr. Neil Resnick here tonight to tell us about his experience. He finished his residency at Maine Medical Center in 2012 and fellowship at Mount Sinai Hospital in New York in August of 2013. So he's only been attending now for a little less than 2 years, but he is, I really applaud him for what he's done in a short time in building up a clinical practice. It's really how I kind of see myself as a future interventionalist. I'm hoping that we can all take his experience to heart. So Neil, without further, the stage is yours.
Thanks, Dave. I appreciate it. Again, my name is Neil Resnick. I'm the Section Chief of the Division of Vascular and Interventional Radiology at Harlem Hospital Center. And I thought that it might be a good opportunity to inform the future graduating fellows now, and also residents who will soon be fellows, as far as how to start your own practice and just some general tips on that might be useful. Now, the path that I took was a bit unusual in that after graduating fellowship, I took a position at a hospital, Harlem Hospital Center, in northern Manhattan, New York City, that really had very little infrastructure set up. And I joined the practice as the sole staff interventionalist and decided I make it my undertaking to build the program and hopefully be successful. So I think we've achieved some pretty good success to date, and I want to share with you my tips on how I did that coming straight out of fellowship and show you it's possible, even though I recognize it's a bit of an unusual path and most people go into practices that have a little more already established. So I call this lecture Picks to Tips, How to Build a Successful IR Clinical Service After Fellowship. Now, as far as disclosures, really I have no relevant financial disclosures. I am a second-year attending. I initially gave a very similar talk at SIR 2015 in Atlanta a few months ago, and at the time, the daughter lecturer had given a very nice disclosure of his own. I think he said something to the effect of that he's a registered Democrat, and so I thought I would give a disclosure of my own that I believe the most valuable service is one rendered to our fellow human beings. This is a statement that I read on a sign posted on a tree at a Buddhist monastery in Thailand, and I thought it nicely encapsulates my approach to what I do in IR, and I hope you guys will also do the same in your new practices. As far as the objectives of my talk, these are lessons that I learned while I was in naval aviation. I was a naval flight surgeon, and the lessons are: be brief, be bright, and be gone. These are really, for any talk you give, these are good lessons. I also want to share with you, of course, the lessons learned in establishing and running IR clinical service after fellowship. So I hope I can achieve all of these objectives. Now, in choosing your first job, I recommend that you choose your first job wisely, of course, and I would consider what factors are critical to you about your future practice. So many of you already have jobs lined up, those of you who are graduating as fellows, and so this might already be a done deal, so to speak, but others of you can think about these things, and also in perhaps your second job, you could consider these as well. So the factors that are critical are going to be geography. Some that's more important than others. Some are very geographically limited for the family reasons or for just where they want to be. Whether you want to be in academia versus private practice, they can be very different, your actual work on a day-to-day basis. Salary, for some people that's, again, critical. how much IR do you want to do versus DR. And it seems as if it's becoming more and more common to have jobs be closer to 100%, if not 100% IR. Certainly my job is 100% IR. However, there are jobs out there, many jobs in fact, that have a very high percentage of diagnostic radiology. When I was looking, I saw jobs that had 50%, sometimes even 60% of diagnostic radiology, and they were still considering it IR positions. They still wanted people who had fellowships in IR. So if you love diagnostic, there are many jobs out there for you, but again, you decide what's important to you. Also, the idea of autonomy versus mentorship, i.e. second fellowship. When I was looking for jobs, there's quite a diversity of jobs out there, all the way ranging from my job, which really involves very little mentorship at my workplace, and to jobs that have 100% autonomy, or very close to that. And on the other side of the coin, there are jobs where you have a very strong interventionalist who's at that practice, and they can guide you and more or less teach you. You can run all your cases by them, or many cases by them. It's more or less a second fellowship, but you really might lose autonomy in the process. I think most important is to identify what your sine qua nons are. My Latin's not excellent, but I believe that means without which not. And so you have to figure what is critical to you. But these are the points that most fellows focus on when considering future jobs. However, you also want to consider how established a practice is versus taking on a project. I would say that's an opportunity, a project. That's the way I look at it anyway. Case focus is also going to be very important. Whether how much you're doing of IO, PAD, fibroid embolizations, vein work, peds, etc. There's such a broad range of what we do, and depending on where you practice, you can do more or less of these things. However, don't be intimidated about going out to a practice and growing it. So you could do any of these things that you want to do, and I'll give you the tools to do that in this later on in this presentation. So you want to consider, as you begin to think about how to approach building your practice, the unmet needs in the community, the command climate, and I'm using a military term there. What I mean by that is in your department. So in whether you're in diagnostic radiology, most IR sections still are, you want to consider how much departmental support you'll be getting in your practice. And also the IR clinical infrastructure. I'll talk more about that. I think that's critical to build if you don't already have it. But I really want to say, not to be intimidated about going to practice, even straight out of fellowship. Again, that's what I did. So as you're considering how to grow your practice, you want to do these three things. You want to take stock of what is. You want to envision your ideal IR practice, and then go ahead and fill in the gaps. It's really that simple, and I encourage you to think of it along those terms. So in terms of taking stock of what is, I encourage you to be humble, be observant, and be a good listener. So in other words, when you start out a new practice, you have to first figure out what's going on. I was very quiet. When I first came to my practice, I didn't try to jump in and say, this is the way it needs to be, and here's how it's going to be. I first just listened, tried to get as involved as possible in my department, in the hospital administration when I could, and certainly in interdepartmental meetings, and tried to involve myself with as many other clinicians as I could to understand what the unmet needs were. So in terms of community needs, you want to think about your hospital size and the catchment area. So in other words, who are you serving at your hospital? You want to consider if you're a trauma center, if you are a stroke center, and then the population-specific disease entities. At Harlem, our population has fibroids, and they're quite common. Renal failure as well, and cirrhosis. I want to build these areas. This is what I decided that I would build. We had very little IR to begin with. It was just a part-time interventionist who came in a couple days a week to do very basic cases, and I decided that given my population, given the needs of my community, these are some of the main areas that I want to go after to build my practice. So you also want to consider what your staffing is, right, when you come in. I came in with a PA who had been just a diagnostic radiology PA for years, because again, they didn't have a full-time interventionist, so he wasn't contributing to IR. We had no dedicated RNs, we had no dedicated technologists, and of course there was the diagnostic radiology administration, but no dedicated staff for IR. So you want to look to see from who's there what you can use to build your team. And I really like the word team, especially in IR. You know, we're a very tight-knit group, and sometimes I feel that the other clinicians, the other staff members in diagnostic radiology don't fully understand why we are so tight, if you will, in IR. But it's critical that you are, because you know things can go wrong, and you want to make sure that you know how each other functions in your team, and that you can trust one another to do things. It's very important to get very close, and I really encourage that. So you also want to consider, in terms of staffing, do you have anyone else there who's going to cover a call? And that's important. I was very adamant to make sure that we, of course, had other people covering call. In my situation, it's the same part-time interventionist who's there also covers call and alternates call. So my call is more or less every other week. And that's worked out fine. But that may not be good for others. And you may want to have more interventionalists and be taking call every fourth week, or you name it. Depends on how many people you have covering call. So I think that's an important point. In terms of IR stuff, again, take stock, see what you have. What's your equipment? Do you have an angio suite? Do you have a CT scanner you can use for procedures? What else do you have? In terms of supplies, do you have the necessary wires, catheters, stents, embolics, etc.? And how about clinic spaces? These days, I think everyone understands that clinic is critical for IR. And there's no question that we've become an extremely clinical specialty. So you want to see what spaces you have and what you can use for, again, future growth. In terms of the clinical infrastructure, it's very important that you, again, look what you have, because you want to look at what you want to build. You want to look to see if there's a schedule of procedures, clinic visits. If not, make one. And that's what I did. I used Outlook and just simply started making our schedule there. There's no really fluid scheduling system. Otherwise, there's a diagnostic radiology scheduling system, but it's a bit rigid for the needs of IR. And so I found that actually just using Outlook calendar was sufficient to make and keep our schedule. Is there a consult service or consultation portal, some way that the clinicians can request procedures? And I say request procedures because, or I say request consultation from you about possible procedures. And I like to frame it in that way because it used to be, and many of you may know this, that IR was a lot different. It grew out of diagnostic radiology, and people would order procedures. So someone would order, say, an IVC filter. They'd order tips, and I don't like that. I don't think that any of us should think that's a good idea. We are every bit as well trained, as intelligent as our surgical colleagues, and we now have the clinical background that many of these folks have, and we're building it. It's kind of normal clinical every day, our specialty. And I think it's important to put ourselves in the same league and consider ourselves the same as our surgical colleagues. So very important that no one's going to order a cholecystectomy. No one's going to order that. In fact, they're going to request that surgery evaluate the patient for possible cholecystectomy. They're going to say patients ready for quadric pain and what have you. And so I designed a portal that they can enter requests and basically tell me what's going on with the patient. But they know now that they're requesting procedures, requesting consultations for me to see the patient about possible procedures, and nothing more than that. You want to look at whether you have clinic and outpatient service, whether that's very important, and that's important not only because clinic is just critical, right? Other specialties, surgical specialties, for example, have clinic. You want to be able to bring outpatients into your hospital. You'll find that for billing, outpatient procedures are important for your hospital, for your department, and they're not only good for the patients, but they're also good again for the hospital and your department. So that's going to be important to build that if you don't have it already. You want to have inpatient rounds, and for obvious reasons, you got to round on your patients, you want to follow your patients, and also an admitting service. I found that for me, that was very helpful to be brought on, and I asked for that, admission privileges. And my GYNs colleagues, they were very, I won't say frustrated by the prior situation, the prior setup, but they thought it was more work to, say, for example, bring in a UFE to the hospital because the patient would then get admitted to their service and stay overnight, and they didn't, it wasn't a procedure of theirs. So they more or less had to follow the patient. They had to take care of everything. They came up in the middle of the night. The patient couldn't sleep. They need Ambien, all the stuff, whatever. And all of a sudden, it's not even the procedure they did. So they were resentful of that. So the first thing I did when I came in, I had the grand rounds with GYNs. And I'll show you that later on in the talk. And I said to them, they asked about this. They asked about, they just assumed it was going to work the same. And I said, no. I'll take the patient on my service. Don't worry about it. They were shocked, and sure enough, every single patient that we've done and that we've kept overnight has been admitted to me, and it's worked out great. Now, having said that, I built a nice relationship with the surgeons because they go to the surgical floor, and they're often willing to. The surgical residents are willing to help as well. Now, once you figure out what is, you want to envision what could be, what you want, what's ideal. And this is, in my opinion, the fun of it, because you could say, for a second, okay, I know what's out there, but put that aside. What do I want? What am I only doing? For example, I love doing fiber embolization. It's just something I really enjoy doing. It's the kind of patients I enjoy taking care of. I also love oncology. I love, various things, but for me, this was the way I decided to approach it, is how do I want to build this again based on what the needs are of the community, but also what you enjoy doing. In so doing, when you're trying to actually put this into practice, once you've decided what you want to build, establish a mission statement. Make it lofty, make it clinical. Okay? Again, you want your clinical colleagues to acknowledge, to respect you as a clinician, and that's critical to the success of your program. You have to also believe in it. Okay, so make it lofty, make it clinical, believe in it. You want to share this vision then with as many people as you can. You want to share it with your team, the administration of your hospital, and your referring colleagues. If I say commentary is anticipated if it's properly ambitious, and I laugh every time I think about that, because when I went to my administrators and I told them what I wanted to do, they started laughing. And I'll show you the mission statement in just a minute. And when they did, I actually thought that was terrific. I said, boy, it's properly ambitious. And but also, again, accept feedback with humility. All right. And stay focused, because it's not all going to be fun and games. You're going to get criticism. People are not going to think that it's possible what you're trying to do, perhaps. But if that's the case, you want to still hear them out, and maybe there's some truth to what they're saying. Some of it may be, who knows, jealousy, or maybe true disbelief. But there's always something to be gained from what someone else is saying, even if it's 99% false or whatnot. You want to, as you figure out how to build your ideal practice, you want to set a broad timeline of goals. And my grandfather always used to say that a goal is a dream with a deadline. And so you want to go ahead and make sure that you begin with the end in mind, and prioritize your goals to accomplish your mission. It's also very important to reiterate those goals periodically at your meetings with your team, with your administrators, and with your referring colleagues. You basically want to keep refocusing yourself and refocusing your colleagues on your mission and how you're working to accomplish it. By doing that, by being somewhat repetitive and kind of seeing where you are along that timeline, you know what you might need to do to keep moving forward, things that maybe you set out to do and have been a little bit behind in certain things. And I find it's very helpful to keep refocusing on the mission and the goals. You also want to be sure to celebrate your successes publicly. I was always taught in the Navy that you want to praise in public and chastise in private. And that's a good way to build trust among your colleagues. And I think it's important to celebrate your successes. So, you know, my hospital, because there was not a full-time interventionalist for many years, and the cases that were being done were quite basic, most of them. And so many of the things that I was doing when I first came straight out of fellowship, of course, when I was at Mount Sinai, it's a very broad training, the very high-end cases that are being done there, and I was eager to start doing high-end cases at my hospital. So from fairly early on, as soon as I made sure I had the right equipment and I had trained my staff on the plan of what we were going to do, I started doing cases like TIPS and BRTO and all these things that were rather commonplace perhaps at Sinai, but had never been done before at my hospital. And when I would do that, I would actually send out a message to all the department heads and even to the medical director of the hospital and let them know the landmark case that we had done. I didn't do it every day. I didn't want to overwhelm anyone. I didn't want anyone to think we were bragging, but we certainly weren't. But I wanted people to know what we were doing and what we were capable of at the hospital. I felt that, one, it not only allowed everyone else to know what they could start referring to us and that we were capable of handling much more complex cases than we've done in the past. Also, it built a sense of pride amongst other department heads and staff members in the hospital about what now the hospital is capable of doing. And I thought that was very important to let people know that we were now doing the cases that were being done at our giant and wonderful colleagues down the street in New York. So here's an example, a theoretical example of a mission statement. It may or may not be the one that I use, and in fact it is. It's my mission statement that I was using to inform my team of what we were going to do and the administrators was to operate a robust clinical service offering the highest level of interventional radiologic care available anywhere in the world. And it might sound a bit lofty, it might sound clinical, in fact it is. Again, I believed in it. And so I decided that this is how we move forward. I got chuckles from our administrators and I thought it is properly ambitious. Short-term goals that I set included building a new IR clinical service, providing full-time service, inpatient and outpatient care, opening new IR and UFB clinics. That's something that I did in my practice. I have a separate UFB clinic given my patient populations and the needs in the community. So again, if you have a community that has other needs, perhaps you have a population that has a ton of IO, you may consider having a clinic that's just dedicated to IO, and you may be able to keep it busy enough that it's worth having that. And I say that because if you can, if it's worth it, let's say the IO example, position it in oncology. That's exactly what I did. I took my UFE clinic and I put it smack dab in the middle of gynecology, where their clinics are. And that was terrific. So now when patients come to see me, they feel as if we are working collegially with GYN. In fact, we are. Your short-term goals also include training IR nurses, technologists, and PA for us, and training radiology residents. Midterm goals for us, continuing to strengthen our clinical service, acquiring new equipment, expanding to a second procedural room, CR suite in our case, and new line, well, we could do new line placements and catheter exchanges. That's what I saw as being realistic for us going to a second, having a second room. And for long-term goals, again, I was looking to strengthen our clinical service, expand to a second IR suite eventually, and perhaps hire a second attending interventionist. All right, so now, how do I get there, right? So you've established what is, you've established what you want to be and what needs to be, and now you figure out how do I get there from here. I countered this sign when not this sign per se, I got this message when I was in Maine. I did my radiology residency training in Maine, and that was great being up there. The training itself was fantastic. The IR was excellent in the exposure I had as a radiology resident. And it was just fun living up in Maine. When I remember driving one day into the countryside, and I got lost, and I stopped at on the side of the road and talked to someone at a gas station, and I asked them how to get to a certain place. And of course, the answer I got was, "You can't get there from here." I'll tell you, at the time, it really annoyed me because I was lost and I was not happy about it. But it's fun. And sometimes, though, it may be difficult to get there from here. You know, you may not be able to get there through a straightforward route. You must expect challenges along the way. Now, I don't know if you guys recognize this this gentleman. This is Dr. C Koop, 13th Surgeon General of the United States. He was under President Reagan in the 80s. And he was really one of the only Surgeon Generals with a household name. And he was impressive. He had bold leadership that he showed during his career. He was involved in preventing tobacco use. He put those Surgeon General's warning labels on cigarettes. He was involved with raising awareness about the AIDS epidemic that was starting to spread like wildfire at the time. And also he supported the rights of disabled children. He actually became famous after he became Surgeon General, but he was a very famous pediatric surgeon at CHOP, one of the first to separate Siamese twins. He actually was my mentor in college, and that's why I show a picture of him. I was so impressed with him, with his career, and I one day remember asking him how he became great. And of course, maybe secretly, I wanted to become great too, and I wanted to know how to do it like he did. And I just was astounded by his response, and this was his response. He said, "I never tried to do something great. I just filled in the gaps where I saw them." And that really had a profound effect on me to stop trying to be great and just trying to make a difference, trying to improve things locally around me, and again, fill in the gaps where you see them. So you don't have to try to be great. You will be great if you can fill in those gaps. So what does that mean, filling the gaps? So like I said, you have to look to see what is, see what you want to be, and in all likelihood, you might need to build or reinforce the IR clinical infrastructure, especially if you're coming into a practice like mine, where there's really very little there, or if you're joining a practice with, say, an older interventionalist who may have been used to the older model of how cases used to come to IR, again, people just ordering procedures directly, and you may be then charged with turning it more clinical, the whole service. And so here are some ways you can do that. You can make sure you're developing a schedule of procedures and clinic visits. I told you already how I did that. A consult service, clinic outpatient service, inpatient rounds, admitting service. Again, I mentioned all these previously. My suggestion would be, if you're not sure how to do these administratively, I would look at your hospital or look around in your practice, look at the GI guys, look at the surgery guys, and figure out how these things are being accomplished in endoscopy and or surgery, because those are really the two areas of medicine that I believe we can model ourselves most after in terms of patient care. Now, I feel very strongly, and I'm sure all of you do as well, that it's very important for all of us to be a real clinician. Right? I say that in that way, in a sort of facetious manner, I often get from my family and other folks that, oh, so you're not just a radiologist, you're a real doctor. Of course, and I don't know how exactly to take that. Yes, radiologists are real doctors, and I am a real doctor as well. But I think what they mean is that you're seeing patients, you're involved with patient care directly, right? We all know that diagnostic radiologists are doctors. You're the brains of the hospital. In my opinion, you're really what keeps the whole place running smoothly. But as an interventionalist, you are not only a doctor's doctor, but you wear a dual hat. Now you're a patient's doctor as well. And this call to arms, I think, is still relevant today. This was a statement put out by Charles Goddard, who I'm sure all of you have heard of at this point, the father of IR, and at a meeting of the American College of Surgery in 1968, he said, "My fellow angiographers, meaning us, prove unwilling or unable to accept or secure for their patients the clinical responsibilities attendant on transluminal angioplasty," and I'll add all of IR for that matter. "They will become high-priced plumbers facing forfeiture of territorial rights based solely on imaging equipment that others can obtain and skill others can learn." And you guys might have seen this, right? You might, in some of your training already, you might have seen that the surgeons, vascular surgeons in particular, bring C-arms into the suites. Others actually have hybrid ORs now, and they've learned some of these techniques. They have the equipment, and they are able to do endovascular work. Similarly, nephrologists, in many cases, might have an ultrasound unit and might be doing biopsies and this sort of thing. So it's really important to go out of your way to take care of patients, to show that you don't, you're not going to, you're not as clinical as these other doctors, and that's why they deserve to do more of these procedures. You're every bit as clinical, and again, I just want everyone to keep that in mind. I'm sure you already are. This paper is also a very good paper if you want to read that and kind of see what that has to offer. The future interventional radiologist, clinician, or hired gun, and I think we all know the right answer, that we're clinicians. So just to reemphasize the point, be a real clinician. As a medical student on surgical rotation, I remember that an attending once told me that you have to imagine that your hand is glue and that every patient that touches you is yours, so they stick to you. That also had a profound effect on me. And if you behave this way as an IR, trust me, you'll never be short of patients. Even little things matter sometimes. I have been told by some clinicians that they like the way I dress my incisions for tubes, drains, and catheters. Everything you do for the patient, in addition to, of course, the patient outcomes and experience, reflect on the care in your section and how likely you are to get more referrals in the future. So I would say you want to strive for excellence in patient care. Don't just try to do patient care. You want to be excellent. You want to show them that you are not only as good, that you have what it takes. And you want to show your patients respect, be extremely humble. You want to walk and talk them through all procedures. You want to make sure that you're not going to try to belittle their experience. Of course, one mistake I'll say that I see a lot of residents doing is when you're about to inject lidocaine or whatever you're going to do, they'll say, "Oh, little pinch." And if you've ever had lidocaine given to you, it is a big pinch, and then it's a sharp stabbing pain when the needle enters, and then it is a terrible burning. So I actually go the other route, and I tell the patients, I say, it is going to hurt like hell. And then all of a sudden, maybe it doesn't hurt that bad, and then they feel like they're heroes. They feel good about it. Oh, it wasn't that bad, though. So again, little things, but if you walk and talk to patients through every procedure, they feel like, wow, this guy just, there's no surprises. I really enjoyed that experience, and I get that a lot in my practice. You want to be sure that, of course, you practice longitudinal care in the clinic when appropriate. And when you see patients, you're happy to see them again and be very pleasant. Even if patients aren't so pleasant always to you, they're sick people. And you want to just show them all the respect that you can give them. They are your patients. They are who you're there to serve. I would really strive to provide better customer service than your competitor services. And, we have, in my hospital, we have nephrologists who will place, Shiley catheters, for example, and I have patients who tell me that, wow, this was so much better than the last time we did it on the floor, or what have you. We placed a lot of gastric jejunostomy tubes, and I get a lot of referrals because the clinicians know that I'm going to treat my patients well, and so they'll send the patients to me rather than my competitors. That's especially true at my hospital of vascular surgery, who also does a fine job, but again, I think if you treat patients well, it goes a long way. And not just patients, but you want to treat your clinical colleagues with respect as well. And I remember hearing actually at SIR this year, one of the attendings, one of the panelists, another presentation, who was saying that he does this, and I do this too, and I think it's important. For example, whenever you address another doctor, you can call them Dr. So-and-so, but then refer to yourself as your first name. It's just little things that kind of show that you're humble and that you respect them. Now, you'll feel it out sometimes. For example, with surgeons, you may want to show them that you are every bit as strong and confident as them, and you may want to call them by their first names. I do it actually at times, but sometimes I do it to make a point with them. So you can feel it out. But I think another way to show respect is to promptly dictate your procedures and write your notes on time. Again, other clinicians who, especially those who have clinical services and have to make decisions based on the procedures that you perform, will want to know that the procedure went well, that they can use the catheter, that there are no complications, no problems with the procedure that they need to take care of now, that perhaps the patient's back to being on their service. Phone call, always help. I call actually after every, anything more than say like a vascular access case, and even sometimes I'll do that with vascular access. I'll call the clinician and just touch base with them, and they love it. In this day and age, as long as you don't violate HIPAA and use names and that sort of thing, you can send text. That helps. I really give out my phone number to just about all of my colleague clinicians, and they don't abuse it. It works out very well. It's a nice way to communicate quickly. And I actually also have a hospital cell phone, so on that you're allowed to use patient names if you need to. So you'll just see what your setup is. We also want to send thank you letters describing findings and follow-up care to referrers. I do this. I do as much as I can do it. I don't always do it in a formal way as a letter per se. Sometimes I'll just send an email. In fact, it's usually an email. Certainly always I call, but I find email is also very effective for communicating. You always want to say yes to procedure requests initially. So that was a piece of advice given to me by one of my attendings during fellowship, and I think that's a great piece of advice. There's little harm in, so in other words, what I'm getting at is if someone, let's say, calls the, control room, and at least in my setup, that's how we have it. If they want to talk to us, they'll call the control room, and let's say they didn't want to put the request into the console portal yet, they want to talk to you first, and they'll say, can you do this? I automatically just, I'll just say, yes, we can do it. Go ahead and put a consult in the portal, and we'll do it as quickly as we can. And it's always a yes first. There's little harm in calling back referrers and recommending that they do something different once perhaps you've had time to evaluate the clinical scenario more. You've gone over the imaging carefully, you've reviewed labs, clinical notes, etc. And you could say, well, you know what, actually, before I place that gastric jejunostomy tube, I really would like to have a CT of the abdomen first, just to see the anatomy. There's little harm in doing that, and as long as they know that you're going to do it, they've already reserved the patient for you rather than sending, say that patient put a consult into the surgery or to GI to have a peg placed. It's basically, again, it's stuck to you. It's your patient now. You also want to stay strong when you're occasionally confronted with difficult cases. Now, this is more relevant, or was very relevant, I should say, to my practice, because occasionally we have some very complex cases, and you know, I look to the right, I look to the left, and I look in the mirror, and that's the guy who's going to help me. So I have very good diagnostic radiology colleagues. They certainly will always try to help me when I ask them questions. I feel it's very important as an interventional radiologist to be extremely confident in diagnostic radiology, to make sure that you know what you're looking at with imaging and you know what you want to do. I think, you know, it's good to reach out to your colleagues. Certainly, it has helped me on occasion. But I got to say, there are times when you just want another interventionist to take a look at, you know, what you have in front of you. And in my circumstance, and perhaps some of your circumstances to come, you may not have that person next to you to look at all that. So you can always ask for a lifeline from your fellowship attending. That's one of the great things about fellowship. They expect it. This is perhaps the look that I got the first time I called my chief of IR at Sinai. This is Rob Lookstein, and you know, despite him giving me that look, he helped me out tremendously. And don't forget about your fellowship attendings. They're there for you, even if they don't make faces. Now, I find it's very important, and what's really helped me in building my numbers, my practice. When I got to my practice, they were doing on average, I'd say about 5 cases a week. And again, a lot of very basic cases, PICC lines, drainages, biopsies. You know, they're fine, they're fun. Nothing wrong with that. But in order to build sort of the bigger cases, because again, I was coming off a fellowship and I really wanted to keep doing the complex cases that I was trained to do, I had to market myself. Now, we've got to a point where it's very common, more common than not, for us to do 5 cases a day. So 5 cases a week, 5 cases a day in less than 2 years. The way you do that is by, again, marketing yourself, and the way, because you've already decided that you're going to be an excellent clinician, you're going to, you know, give the full gamut of IR as best you can. Now you want to go out to the clinicians and start giving grand rounds as soon as you can. I found it was very helpful. My first grand rounds was the GYN. I also get very involved in multidisciplinary care conferences. Again, the more that the other clinicians see you there, see you as one of their colleagues, the more they're going to refer to you, and especially when you're there at the time of the discussion about the patient, they'll chime in, they'll ask you to chime in and give your opinion. And if they don't, that's fine. Then you can still chime in and give your opinion. And when they realize you have something to offer, you'll find that they'll start sending those cases to you. And I really enjoy going to surgical M&M each week. At my hospital, there's a combined grand round of surgical M&M every week, and I go to that and I love it. I think it's the best because a couple of reasons. One, again, it forms a very strong bond with my surgical colleagues. I think that's a critical bond to make at your hospital. And I also love it because, you know, this is where they show their dirty laundry, if you will, and it's great because you get to see them talking, you get to see them what outcomes they've had that maybe they weren't so happy with, and I've certainly had on more than one occasion where they turned to me and said, Neil, what would you have done? What could we have done if you were involved in this case? What could you have done? And I think again it keeps everyone humble, to including the surgeons themselves, to have you there and to having you see their M&Ms. And just again, you know, if you're all talking about your these cases, I think you find that you have a closer bond, and that's really what you want. You want to make sure that everyone sees you as one of them. So you want some of the hospital board. That's critical. You know, the more that you can be involved with administration, the better. You want to have IR have a real strong presence at your facility. And I would encourage you to, as much as possible, work yourself up through the administration. You don't always have a lot of time to do that, but you know, as much as you can give, you absolutely should do that. I also, in addition to all the above, I, as quickly as possible, started arranging dinners with the chairs and chiefs of my colleagues' specialties. So, in other words, I was chatting it up with the chief of nephrology, for example, and he said, we should talk, go to dinner sometime and talk about this more. And I did that, with surgery and other specialties as well. And I just found that, if you go outside of work and you're chatting up with them, and you just, it's really a nice way to, again, get closer to these people who are then going to refer cases to you. Here is the first grand rounds that I performed at my hospital. Again, I envision building up a strong UFB program. And this is my first grand rounds was with gynecology, as I mentioned. You want to make sure that when you start doing these things, that of course everything is strongly based in the current literature out there. And there are many ways to do that. I mean, one, you might have presentations, canned presentations that you developed or can share with your colleagues in residency and fellowship. I think a good way to do it also is, and I wish I had done a little more of this, I'm starting to do it now, but if you go through the presentations that were given at the SIR conference each year. You can find presentations that are relevant, pull out tidbits, look at their sources, and create your own presentations from those. And again, make sure it's excellent. Make sure that you're showing how you're going to help those services to take care of their patients, and which then become your shared patients. And but I think it's really important to make sure that they understand the benefit that they're going to get out of sending patients to you. I also believe, in addition to marketing yourself to your colleagues, that it's okay to market yourself to patients directly. And that's a newer concept that people are just starting to get more comfortable with, some of us more than others. The private practice folks seem to have adopted that more quickly than, say, those of us in academia. I actually come from a sales background in terms of my family, and so for me it's very comfortable to be able to talk about what I have to offer with patients. And I think if you're confident in your procedures and what you do have to offer, there's no problem with letting people know what it is you do and how a good job potentially you could do for them. So you can do this during clinic visits, of course. You can make sure you talk to a hospital public affairs office or a clinic marketing team, whatever is at your facility, the specific administrators who will handle this kind of thing, because you have to make sure these things are clear through them. That's absolutely necessary, otherwise you get in real trouble. They often can help as well, and they did so with me to help me arrange some events in the community where I went out to some of the community boards and were speaking to groups directly about the procedures that I have to offer. Industry may also be willing to provide assistance. And for example, you see a brochure there that one of the companies was able to put together for me, and it really is great. I give it out to my patients. It has my name on it, it has my title, contact information, etc. And I made sure to go through my hospital public affairs office, make sure to clear with them that everything was copacetic. Now, if you remember, this is the presentation I gave to the gynecologist. This is the presentation that I give to patients when they come to see me in clinic. This is from an ad that I found on the internet, that picture, and it's talking about UFE, and I kind of joke with the patients, and I let them know that I can't necessarily make them jump so high or have such a flat belly per se after the procedure, but I believe that I can make them this happy, and they always laugh. And so I think that's a good way to approach things. Now, you're going to want to strengthen your team, right? Again, I like the word team for our field. You want to augment your IR staff as you grow. So when you first get there, depending on your setup, you may or may not need so many people. I found that as we grew quite quickly, from all the marketing and care, the good care that we were providing, that we started getting more and more patients. And quickly there's a need to augment from just my single PA to then start adding on dedicated IR techs, nurses, etc. I now have an administrator who's dedicated just to IR, and she's fantastic. She handles our phones in our control room, sets up all of our clinic appointments, etc. We're also adding on soon an MP, and also building the dedicated staff for technologists and nurses. Now, it's also good, of course, to have more staff as you grow to take call coverage. Presumably, maybe as I get older, I won't want to always keep doing call every other week. So it's important to think about team building. I recommend Team Steps. This is a program that, if I state this correctly, came originally from the military. If not, at least I know the military uses as well. And it's just a great program for team building, so I encourage you to use that. Now, you need to keep in mind, as much as you want to go out there, guns blazing, and you will, and you'll do a great job, I'm sure. You want to be realistic, though, about your short-term, mid-term, and long-term goals. So as much as your mission statement should be lofty, clinical, and you should really truly believe in it, you also should temper that with realism, that you may or may not fall short of some of your goals, and if you do, you have to refocus. So be flexible to changes, know your limitations, don't get discouraged, and realize that politics are everywhere. I see that a lot in my practice. And most importantly, have fun. All right, it's a great job. I wouldn't trade what I do for the world. I love it, and I let patients know how much I enjoy my practice and what I do, and I tell them that, it's like minimally invasive surgery, but we don't call ourselves surgeons because we're less invasive. We don't cut people. Again, just be enthusiastic, be caring, be compassionate, and persevere, and you will succeed. I guarantee it. Here's some pictures of our staff as we grow. Any questions?
All right, so we've got a few questions here. Let me just read it a little small. I think the first one here says, could you discuss briefly your experience with being hired into this position and how you balance your productivity, justifying your salary while initially doing 5 cases and growing the practice?
I didn't hear all the question. I only heard part of it, but justifying productivity to justify salary. Can you repeat that?
Sorry, here, let me try that again. And just for anyone else who's listening, if you have a question, you can ask it in the question box, and then I can read it out loud. Or you can, there could be a button where you can raise your hand, and then I can try to allow you to speak. And then I'll reread the question. Can you hear me better, Dr. Anthony? Hello?
Yes, go ahead and say it again. It's a bit muffled at the end there. The question.
Okay. All right. Yeah, I was just wondering if you could hear me better. So the question is, could you discuss briefly your experience with being hired into the position you were hired in, and how you balance the productivity while initially doing 5 cases a week and going into practice?
Now, I'm not sure if that question is in reference to productivity in terms of like RVUs, that sort of thing, or in terms of whether or not I'm just working my tail off, and that sort of thing. In terms of, I'll try to answer both. If I don't answer the question, please just use raise it. I'll try to do so. In terms of the RVUs, I guess I've been a bit fortunate in the sense that I've had a lot of support from my chair of radiology. In general, I'd say that the RVUs that we get, while they're great from interventional, sometimes, I may be mistaken, but I believe that you actually can get more RVUs by, say, adding chest x-rays and other things like this to your practice. And so some people will be asked to do that for sure in their practices. I have friends who, in their new practices, have been asked to do that by their chairs. But again, I've been fortunate. In my case, because I'm the only interventionalist, I'm just really too busy doing the procedure to do that. So I hasn't been demanded of me. But in terms of let's say my work life versus home life or that sort of thing, it's been busy. Work's been very busy. So I find that I try to do as much as I can between procedures. It's often I do stay a bit after to finish up whatever work needs to be done, prepare for the next day, etc. I'll say you really have to be sure to be as efficient as you can be, and you have to be willing to design your schedule such that, and use your staff appropriately, such that it really helps you as much as possible. So, for example, when I first started, my PA would come in early in the morning, and then he would leave pretty early in the afternoon, just for that's when his workday would finish up, and I would have to be there a couple hours after. And then that would create a situation where people weren't really being consented, or really consented for the next day. And in other words, then the next morning would come, and then the patients had to be consented, and it would slow things down. And so now we're actually transitioning and talking about how we're going to change hours so that the PA can come in later and then do the consents in the evening and this sort of thing. I think it's going to really speed up the practice. So there's going to be a learning curve to all this, certainly it has been with me. I recently saw a diagram where they were showing success, and people tend to think that it's a linear curve with a positive slope, and just keeps going up and up and up. But really, it's just a squiggly zigzag line, and you have to anticipate that you're going to have to keep changing things around to make things as good as possible. I hope that answers the question. If not, you can feel free to ask again.
Yeah, I think that did. We have a second question here, which is the asker says, how do you suggest IR build a vascular practice where vascular surgery / cardiology have a hold on the non-invasive lab and endovascular procedures?
So I guess the question really is there a way to have a more or less a center within your hospital that's truly an a combined interventional suite, or suites, and then a combined interventional practice? Is that more or less what they're asking, like how to do that?
I believe that's what the question
with cardiology.
Yeah.
Yeah. So I think, idealistically, or I'd say ideally, and perhaps idealistically, I think that's great. I think that's really the way it should be. I will tell you in practice that I've heard time and again that it really is very difficult to do that. There are some centers who have done that for sure. I know that Miami Vascular would be probably the most renowned example of that, to my knowledge. And I think it's something certainly to strive for. It's going to really depend on where you go and what the current setup is. I think in my practice, there's potentially ability to do something like that. But there's a lot of practical concerns as well. For example, if there's not a common area for you all to, if there's not interventional suites already set up for you to practice together, then that's a very obvious, reason why that might not happen. For example, in my hospital, in my floor, the interventional suite is in radiology. The cardiologists are on a completely different floor with their angio suite, and then the surgeons are, of course, in the OR, which is in a totally separate building. And so it's going to depend on your situation whether or not that's even physically possible. It's not, again, cheap to build interventional suites. And I've asked to do that. We have a brand new building in my hospital that's gorgeous, and I think everyone's trying to move into it. It's where the ORs are. And I've been trying to move us into there as well, and trying to see whether or not cardiology could join and could really be a combined center for interventional practice. The problem also is it comes down to some basic billing things. The way the practices are different in terms of cardiology is often, it's even more clinically based. No one can argue that. It depends on the cardiologist and what kind of practice they have. And then vascular surgeons are also doing other things too, like, they're doing open surgery. So I think it becomes difficult to work together. And then there's financial reasons why people might want to do the cases rather than have you do them, and maybe vice versa as well. So I think ideally it's the way it should be, but in practice it's very difficult to pull it off. I will say what I do, however, is I try to build relationships with cardiology and vascular surgery to the extent that if that were possible at my hospital, for the physical concerns and financial concerns that I mentioned, that we would do that. So we're all very close, and I've worked very hard to try to negate any possible conflict as much as I can, and let them know that we're all on the same team. We're all here to take care of the patients. I have a little bit of an advantage in the sense that my salary is not reflected directly by the number of procedures that I do. I'm not, I haven't built 5 cases a day so that I get paid more, because I don't, but because I think it's the right thing for the patients, keeps my day interesting, and so I think that we have the advantage that, again, we're not getting paid per case. I think if you are in that situation, there's going to be those issues you can work through as well.
Alrighty. The next question is, except that it kind of keeps flipping around on me a little bit. So one of the questions here is, so the asker's asking how your practice building has been reflected in your reimbursement. Does the hospital appreciate your efforts? And what can fellows going into practice expect if they're in a situation similar to yours, building a small practice from the ground up?
Well, I only heard the first part of this, so you can repeat it. Unless it's not valuable.
Muted.
I heard that how does my practice...
Let me try. Neil, can you hear me?
Yes. Yes.
Could you hear? All right, let me repeat that. Farheed's microphone's kind of having some issues. Basically, they wanted to know. Marcia is asking, has your practice building been reflected in your reimbursement? Does the hospital appreciate your efforts? And what can fellows going into practice expect if their situation is similar to yours, in that they're building a small practice from the ground up?
Unmuted.
Yeah, great questions. You know, as far as I look at it as 2 separate things in terms of what I build and then what the hospital is able to reimburse from what I do. And I will say that I look at it that way because initially when I came in, I started doing many more cases, especially outpatient cases, fibroid embolization in particular, but also dialysis and other outpatient procedures. I was able to really build quite quickly. I thought, wow, we must be really raking it in, and that would make administrators very happy and what have you from a financial point of view. And it's much more complex than that. I work at a city hospital, and there are a lot of contracts with different HMOs and other things where it's not quite as cut and dry as if you were at a private practice institution that the people who have say insurances that are paying a very high rate for these procedures. So I guess the point is that my thoughts that maybe I was bringing in tons of cash for the hospital, I don't know if that's been substantiated. And I've gotten to a point where I'm a little bit immune to it, and I say, you know what, I'm doing the right things. Whether or not the hospital collects for all the work that I do, that's really more or less a separate issue. It's not entirely a separate issue, I have to say, because really the more that you can help them to collect appropriately, the better. But it's really a pain to do that. I actually sent them the coding updates and from SIR and kind of recommended coding courses they could go to and all these things because I was trying to encourage them to bill appropriately and to collect appropriately for the procedures that I was doing, knowing that once more money comes to the hospital, to the department, then it's not only necessarily your salary that might be increased, because again, for me, it's really not, but at least there's more money that you can use to buy even more equipment. Buy an angiojet machine, for example, or buy a new interventional suite. And that's kind of what we're looking at now, is getting a brand new interventional suite this fiscal year, which is going to be really exciting. So, but again, you can only go so far. You can only do so much. You're too busy, or hopefully you'll be too busy doing the procedures than to get too bogged down in the finances of it. And I would probably encourage you to not get too bogged down in the finances, because you should really be trained and focused on the clinical aspects of your care. Now, remind me the second part of the question, please.
Sorry, the second part was fellows going into practice. How can they expect what should they expect building a small practice from the ground up?
Well, I think that you can expect a lot of what we just talked about. I think I went through it. I guess I'd want to know exactly more specifically what the question is in terms of expectations. I mean, are they talking about? Oh, I think there was another part of the question that mentioned, is the work appreciated by the administrators? Now, I will say that as much as the whether or not the finances are there or not, you would think they should be, right? I mean, but I always say, look, I can hand you a lot of cash. Whether or not you decide to take it from me, I'm handing it to you. Decide to take it. That's up to you, and that's kind of the way I look at it with my hospital. But in terms of appreciated, I will say that well, I love what I do because I am very appreciated at the hospital, and I do think that in a smaller practice, you will find that the appreciation can be much greater. I mean, that might not be true in everyone's situation, but it certainly has been true in mine. I can only imagine going to one of the larger hospitals, for example, the one where I trained, and as a junior attending, I think again you have lots of mentorship, a little less autonomy perhaps to do what you want to build and what have you. But I think that when you're sort of a big fish in a small pond, if you want to use that analogy, you really have a much greater effect on the greater IR presence in the hospital and throughout the community. And it's a lot of responsibility as well, but I think that the reward that comes with that can be tremendous. So I would absolutely encourage you to go out and build, your practice at a smaller hospital. I think it's been a great experience for me.
Okay.
Also, I'll just comment, by the way, that I think my patients are the greatest, and I hope everyone thinks that of their patients. But mine are extremely appreciative, and that's not that maybe affect my city hospital, and they may not always expect some of that care that I give, but I think they're just so appreciative of the care that my team gives. And I think again, same concept that when you have a smaller practice, you have more control over the product that you deliver with your service. And so I think that that's kind of nice to have that level of control over your service, and we're very nimble. So if, I'll give you an example, just the most basic thing that we do. Unfortunately, we don't do too many of these anymore. PICCs, that is. I'm actually in the process of building a PICC service that one of our IR MPs who are coming on board will bring on is going to lead the service. But I used to put a little bit of gauze over the PICC at the very end before I put the bandage on. That looked really nice. And so one day I heard from one of the administrators, one of the nursing administrators, that absolutely not supposed to do that because you want to be able to see the site where the biopatch is, and you want to see if it's getting inflamed and seeing if there's an infection and this and that. It made a lot of sense to me, And so from that day forward, I started instructing my PA, who I trained to do PICCs, and of course my PICCs that I started placing, I started not placing those gauzes over them so you could see them better. So very nimble. It's nice to be able to make changes just like that, and the service just gets better and better very quickly.
All right. There's another question here. One of your residents, actually, Dana, is asking you a question about regarding diplomatically changing ideas and already established views in a hospital. And she's saying that you gave us a few pointers, such as marking yourself and not initially refusing procedures, but any other tips about managing that on a more personal level?
Dana. Thanks for your question. So repeat the very first part of that. So the question was about, say that again?
The question is, it says, my question is regarding diplomatically changing ideas and already established views in a hospital. Any other tips to manage that on a more personal level? And you gave us a few pointers, such as marking yourself and not initially refusing procedures. And just, I think the person's asking about any other tips that you might have.
Yeah, no, I think it's a great question. And the fact is that as I mentioned on the last slides there, that politics are everywhere, and there are a lot of preconceived notions about the care that's given, and I, both within the hospital and without. And I know coming into my practice, there were just a lot of people who, when I told them I was going to work at Harlem Hospital, they, for whatever reason, at the city hospital, or they had, maybe in the past had heard from someone that maybe the care that someone received wasn't as good, or whatever reason, there's some preconceived notions about the place. And I just personally just shrugged it off. Just said, look, again, I'm not going to deal with even what is, deal with what used to be. And I think if you just stay the course, you just, no matter what comes your way, just keep doing the right thing and keep operating at the highest level possible on an individual patient level. I think that, again, it's filling in the gaps. You're gonna, it's that same concept. You're gonna end up doing something really special, with a lot of work, and it's one patient at a time. I find that with other services, they know now that whether it's nephrology or surgery or GI, I've heard them talking to the medical director in front of me, where they'll say, like, oh, Dr. Resnick's great, like, he always goes the extra mile. I call him up, and he does this, and he does that, and he gives this advice, and he sees the patients, and they're just so excited about it. And, I mean, to me, this is just being a good doctor, just being a good clinician. It's not about anything more than that. It's if I were a patient, what would I want? How would I want someone to treat me? And I guess people have told me in the past that treat each patient as if they were your relative, I guess a relative that you like. And so you want to really, I think as long as you do it on a patient-by-patient basis, do the best thing possible for them, that don't look at necessarily what people might have thought in the past, or just go for excellence, strive for excellence. And, even if you, I guess what I say, strive for perfection. If you achieve excellence, that's good enough, right?
All right. Anyone else have any other questions? Dave, anything from you? All right. I guess.
No, I mean, Neil, I just want to thank you again. Yeah, thanks again, Neil, for joining us. I think we had a great turnout. I think a lot of great insight. We will upload this to our YouTube channel for those of you that were not able, for those of you that think somebody else would enjoy watching this. And thanks again.
Thanks for coming out, guys. Good luck to you.
All right. Thanks, everyone.